Hi, this is Brian Wormers recording a lecture about the care of the patient with CNS problems, including MS and ALS, for medical surgical nursing at the University of Sioux Falls. So learning objectives, we're going to talk about MS and ALS and how to assess those patients. We'll look at nursing priorities for patients with MS and ALS. We'll talk about some of the nursing interventions we can do for those with MS and ALS, and we'll talk about patient teachings and community resources for people with MS and ALS. So when we talk about multiple sclerosis, remember that the pathophysiology of this is that there's autoimmune destruction of the myelin sheath related to upper motor neurons. This is a chronic autoimmune disease that unfortunately is progressive. This is hard to diagnose, and unfortunately multiple patients will have multiple hospitalizations prior to a correct diagnosis with this one. Our cause is really unknown. It's likely involves viruses, genetics, and or environmental issues, but we're still working on the specifics of this. This disease usually occurs within women between the ages of 20 and 40 years old and is progressive in nature. Subjectively, things that they might notice would be a history of vision changes, mobility changes, and sensory changes. You can ask if these symptoms are intermittent or becoming worse over time. Some factors that might aggravate those symptoms would be fatigue, stress, and temperature extremes, and they might even have some behavioral changes associated with this. Objectively, so you're going to do a comprehensive neurological exam, looking at mobility, looking at their DTRs, seeing if they have an unsteady gait, or if there's any cerebellar symptoms with this. Visually, you're going to see if they have any blurred vision, diplopia, or decreased acuity, or nystagmus, and then ask them about bowel and bladder dysfunction. Psychosocial assessment, so any cognitive changes lately, what has been going on with them, has this progressed, has it changed? Initially this tends to look like anxiety, but then as it progresses you're seeing more and more cognitive changes, including apathy, emotional lability, and depression. Laboratory-wise, you're going to see some abnormal CSF results. CT, MRI might have some changes on that related to some of the plaques, and then evoked potentials of EMG might be abnormal as well. Some of our nursing priorities, so activity intolerance, if they're not able to move and do ADLs and do those kind of situations, they might have some altered coping, risk for impaired elimination, swallowing and communication, and then impaired sensory perception. So what do we do with this? So planning and implementation wise, we're going to try to have them be as independent as long as possible with their ADLs. We want them to be free of complications from immobility. We're going to try and work with control of bowel and bladder, and we're going to work on adapting to that disease and trying to make them as functionally independent as possible. Intervention wise, so adequate rest, combat that fatigue that they might have. Put an eye patch on if it's needed to try and strengthen up a weaker eye. Assist with bladder care, self-catheterization if needed. Alternative medications may be beneficial with this. There are some meds out there that some people are studying. I'm not officially citing that this is helpful, but realize some people might find them beneficial. So make sure you're asking about alternative medications as well, and then help the patient verbalize any concerns that they might have. Collaborative care, so some of the medications that we might do would be beta interferons, trying to modify that course of the disease and minimize it. Glatiramer acetate, so it's similar to a myelin-based protein that we're trying to give them and support them. We can give them monoclonal antibodies that hopefully bind with WBCs to prevent further loss of the myelin. We can give a chemotherapy drug that's going to reduce the disability and reduce relapses. Immunomodulatory medications, trying to decrease that disease process, as well as immunosuppressants like corticotherapy. So, if they have any spasticity, baclofen, diazepam, or dantrolene can help with some of that. So, delphamino, I can never say this one, delphaminoprimidated improves walking ability. You are not tested about your ability to say these or write these, or even I am not going to drill you on the type of meds for the therapy of MS. But realize it's all supportive care with us, trying to minimize side effects. So other things, medications to manage bladder dysfunction or antidepressants. Community-based care for this, so rehab might be something to do to improve functional ability in the short term. Otherwise, long-term care facilities as they progress. Try and keep the home free of any clutter. Try to avoid any overexertion related to stress, temp extremes, or people that have infections. We do want to do some teaching on drug and try and get them into regime of when to give the meds, how to give the meds, and set that up appropriately. PT and OT, of course, to help them navigate their day, increase their muscles, and work towards independence. Adaptive equipment as possible, work with family for coping strategies, and then, like I said, long-term care facilities if necessary. Great resource for family and the patient would be the National Multiple Sclerosis Society. Now moving on to ALS. So this is a disease of both upper and lower motor neurons, so that distinguishes a little bit between this. This is characterized by progressive weakness, muscle wasting, and spasticity, leading into a paralysis. So the muscles lose their innervation, they weaken, they atrophy, and then they die. So unfortunately, they can get spastic from this, and then death will usually occur within 3 years of an initial diagnosis of this. Unfortunately, we don't know what's causing this, and we don't have a great cure for this yet. Initial subjective assessment we might see is that they're saying that they've got some fatigue, muscle atrophy, some spasticity, or some weakness. They might have a nasal quality of their speech, or dysarthria, or dysphagia, and they might have some cognitive changes. Objectively, so they might have some atrophy of the trapezius muscle and sternocleidomastoid muscles, and they might have some weakness to that respiratory muscles as well. Clinical findings, of course, will help with the diagnosis of this. Other things you might see for diagnostics would be CK might be elevated, your EMG might be abnormal, and your PFTs, your pulmonary function test, might be abnormal as well. So what do we do for this? So nursing priorities, impaired airway clearance is a big thing. So as they are losing that muscle strength of the diaphragm and their upper airways, they're going to have problems with coughing, swallowing, and breathing. And so we want to support that as much as possible. They could have some activity intolerance, some discomfort or pain, and then of course altered coping with this. Planning and implementation with this, so trying to maintain optional functioning until the end of life care is resumed. There are some different medications that can extend some survival time that you can kind of see here. But of course, then there's other meds that can be more for supportive care for pain, fatigue, spasticity, secretion, sleep, etc. Physical therapy and speech therapy and occupational therapy definitely can be used with this. Speech therapy especially related to the swallowing and airway issues. Ventilator support ultimately will become necessary with this, and so we can protect their airway and try to work with that as much as possible. Community-based care, so some of the things that we can do that way is, work with the family and the patient to talk about advanced directives early on in this, then transition to palliative care and hospice, and then tie them in with the ALS Association as appropriate. So that concludes this lecture. If you have any questions on this, please reach out to me.